According to the World Health Organization, COVID-19 has claimed more than 6.3 million lives globally since 2019. Viral pandemics are rare, but an increase in global economy with easy, fast access to international borders now threatens the rarity of a global pandemic. It is up to current and future leaders to pave policies and introduce global standards that can effectively combat novel infectious disease in the context of health equity to minimize fatal consequences which disproportionately befall marginalized groups. Our recommendations take place within the context of the social determinants of health to minimize the impacts of another pandemic from multiple angles and maximize the health outcomes for all individuals.
Economic stability was immensely challenged during the pandemic. Health services, including acquiring health facilities for infectious cases and arranging national quarantine efforts, proved to be a huge expenditure for the health workforce. Meanwhile, a series of economic consequences to social distancing and quarantine, such as the closure of industries and soaring unemployment rate, made health services even more unaffordable for the average person. Therefore, our first recommendation would be to set up an emergency health equity fund following the guidelines of the IMF, regulated by the Department of Health, which will then be streamlined to health workforces where primary and secondary prevention when needed. It will ease financial burden and allow universal access to health services. In its implementation, regulation of funds will be managed by increased spending oversight with external audits and continuous reports of spending.
The physical environment also influences our health outcome. During the pandemic, the homeless population experienced great challenges in adhering to public health directives such as physical distancing and quarantine, without adequate hygienic living circumstances. Consequently, they were at a greater risk of infection. Transmission in dormitories and group living environments was significantly high too. To suppress transmission, we propose to ensure safe living conditions by preparing public housing which can be used to shelter and protect homeless individuals during future pandemics. We note to take a trauma-informed approach to care to build rapport and trust. We also want to introduce and enforce housing regulations, such as limitations on the number of people living within a certain area, that are decided and enforced by local health governments. Having sufficient public housing and holistic support networks are also important in cases where these regulations cannot be met.
Another influential factor during the pandemic is health literacy. The prevalence of technology has led to an increase of people acquiring health advice online, which also facilitates the spread of misinformation. To address this, our third recommendation is to increase digital and health literacy for all populations. One way that the healthcare workforce can do this is to equip the public with the right tools to find credible information online. Studies have highlighted the benefits of health information education programs, which can be tailored for different target audiences, such as children, older adults, and those in rural areas. Additionally, we can also improve the infrastructure and policies that impact how people appraise information. There is an increase of health information on social media, and we suggest implementing systems that show evidence-based health information as verified and credible.
Globally, existing health inequities are further aggravated when health systems are overwhelmed in pandemics, revealing inadequacies in preparedness. In addressing this, for our fourth recommendation, we suggest that the health workforce increase communication capacity with local communities, leaders, and youth. Health messaging evokes more positive health behaviors when health workers engage with communities rather than just deliver messages. This amplifies marginalized voices, bringing vital conversations around health inequities into the limelight, allowing planning which targets these vulnerabilities. Therefore, we advise for the inclusion of community, tribal, religious, and youth leaders in the development of equity-informed health interventions. This also helps disease control through increased community participation. It is important that these cooperative relationships are built early, so that if and when the next pandemic occurs, local health systems already have the trust of their communities for effective health interventions.
The status quo proves slow response to infectious diseases due to systemic inadequacies in reporting and PPE supplies. Studies show that most notifiable diseases have a reporting completeness of less than 40%, predominantly due to lack of easy access to reporting systems, making it difficult to detect novel disease early. After detection, adequate response is limited to higher income countries with greater access to PPE and respiratory equipment. Even with greater access, high-income countries fall short in supplies with an estimate of only 70% preparedness. Shortfalls lead to reuse and contamination, which inadequately limit disease spread. However, case studies like Taiwan show quick identification of disease, and appropriate PPE supplies can reduce outbreak. Therefore, our fifth and last recommendation is to promote global systemic preparedness by creating a streamlined infectious disease reporting platform for healthcare professionals and set minimal PPE and life support inventory requirements.
In our current global health system, where we are more connected now than ever, we recognize that interdisciplinary collaboration is absolutely essential for effective, equitable health measures and pandemic preparedness.